I'm Jerry Bloom, and I've worked on issues of health system strengthening and health system development for quite a long time. One characteristic of the health sector is the emphasis given to global policy prescriptions, which are often seen to establish universal targets. In this lecture, I will explore the evolution of the policy goal of universal access to primary health care. In the first part, I will discuss the Alma Ata Declaration, one of the most influential global policy statements of the 20th century, and situate it in its context of the immediate post-colonial period. I will then explore the many political, economic, social, and demographic changes that have occurred since the initial formulation of the primary healthcare strategy. In the final part, I will discuss some of the ways the initial policy is having to adapt to a radically changed context. In doing so, I hope to stimulate thinking and debate about the role of global policy targets in the complex and rapidly changing context of the early 21st century. In the first part of this lecture, I will discuss the Alma Ata Declaration, a key global health policy prescription from the third quarter of the 20th century. In 1978, a major policy statement was produced jointly by the World Health Organization and UNICEF, and it became colloquially called the Alma Ata Declaration because it was based in a meeting in Alma Ata, and formed the basis of global health policy for the next 25 years. First, I just want to look at what is it in terms of health policy. Well, one way of looking at it is simply as a position statement by international organizations. At that time, the WHO and UNICEF were the key organizations working in the health sector. But beyond that, it also was a consensus statement. This was produced in the middle of the Cold War at a meeting held in the former Soviet Union, and produced a consensus statement on health system development strategies in the immediate post-colonial period or the post-revolutionary period for many of the Asian countries who had set up communist governments. So it was a consensus international statement in a time of a lot of contention. Others have looked at it as a state-of-the-art statement on how to organize primary healthcare services, so a technical document. And others have treated it as a political statement and a vision for the post-colonial period of an ideal health system. So this one document seemed to have all these different meanings. What did it say? Well, its key statement was the government is primarily responsible for financing and organizing health services. Priority should be given to the common and treatable problems. At that time, there were mostly acute infections. There should be less reliance on doctors and more on people who have less training, and so there should be a major increase in training of people with lower levels of skills. Prevention and health promotion should be emphasized, and community participation should be encouraged. Where did all these ideas come from? In the period after the Second World War, there'd been a lot of discussion and political debate in Europe and in North America about new ways of financing health services and increased responsibility of government for financing health services and providing them. In Britain, in the National Health Service, a National Health Service was established in 1948. In the country I come from, in Canada, in the 1950s, a hospital insurance scheme was established, and by 1968, primary health care was also financed. But what had happened since the 1950s is hospital costs had risen, and there was a growing pressure and a growing discussion on how to control costs by strengthening primary health care. Meanwhile, in the colonial health services, in the 1930s and after the war, there had been an increasing emphasis on medical assistants and health assistants who would provide services for the residents of colonial countries at a lower cost than for the settlers. So the colonial health services had created models, particularly for lower cost primary health care. The American military health services, well, a very stark fact was that there were more deaths in the American war in the Pacific from malaria than from any kind of military action. And one of the key factors that led to American success were the large-scale malaria eradication programs. And this example was moving into global thinking. And finally, the command economies and post-revolutionary reconstruction in many countries, first in the Soviet Union and then in China and Vietnam. Parties had come to power after a long period of civil war and military campaigns, and they'd already developed mechanisms of improving health care and caring for people under a wartime context. And in the post-war period, they'd had major reconstruction and given high priority to basic health services. All sorts of ideas came together by the time people met in Alma Ata. One thing that's common, despite the contention in the Cold War, is there was pretty much a shared understanding of the central role of government in leading the rapid construction of a modern economy and, by analogy, in leading the rapid construction of a modern health sector. What did implementation of this policy look like? It was very common across countries with very different political orientations. Almost everywhere there was a major construction, first of hospitals in the immediate post-colonial period, and then of large networks of basic clinics to provide primary health care. There were major increases in training of doctors initially, and then in many countries of nurses and paraprofessionals. So many more health workers were trained. There was the creation and scaling up of public health programs, immunization, tuberculosis, malaria control. A number of programs were created and scaled up. There was a large increase in procurement and distribution of pharmaceuticals, since now the attempt was to provide everyone with access to drugs. And there was training and deployment of community health workers in many countries. So what's very noticeable is the pattern of implementation was very similar in many different parts of the world. I put this slide up to show how a retrospective thinking, in this case by WHO, of this long process, looked at it in terms of building blocks for assembling a modern health system. It sees the health system as, in this case, 6 blocks that were created and fitted together like a jigsaw puzzle to build a modern health system. These included service delivery, facility construction and maintenance, strengthening of programs, and management of facilities and programs. There was a health workforce, major increase in training, management, supervision, and payment of health workers. A major importance of information for managers in the health sector, but also for users in the form of health information. Commodities, the production, procurement, and distribution of medicines, vaccines, and technologies. And financing, raising and allocating sufficient funds to ensure access. And finally, leadership or governance, mechanisms for planning, monitoring, regulating, and making the health system accountable. But what I think we should notice in terms of this section of the lecture is the degree to which this is a rather static view of starting from not very much, creating the building blocks and fitting them together into what is seen as a modern health system.